Medurstand Understanding Medicine.
I'm Professor Azizur Rahman, and we have covered atrial enlargement in the last video, and today we're going to talk about ventricular hypertrophy. And before we discuss ECG criteria of left ventricular hypertrophy and right ventricular hypertrophy, I must say that this remains a poor and very insensitive and not very specific criteria for the diagnosis. There was a time when we did not have any better means of diagnosing LV hypertrophy or right ventricular hypertrophy, and we used to rely on ECG and X-ray and also on our clinical finding. But these days, echocardiography is available. So whenever you actually suspect left ventricular hypertrophy or you want to rule out left ventricular hypertrophy, and you must go for echo. Absence of left ventricular hypertrophy on ECG does not actually rule out that condition because it is not a very sensitive criteria. Only when somebody has gross left ventricular hypertrophy and maybe additional ischemic changes, only then ECG would show, so that would be very late. And particularly in hypertension, we know that left ventricular hypertrophy itself actually adds to the morbidity related with hypertension. So we want to know early if somebody has hypertrophy. So I think with this disclaimer that ECG is not a very sensitive indicator, echo is at least 10 times more sensitive, and echo is now readily available. So echo is definitely the gold standard. So, but since we are doing ECG module, so let's cover this ECG module. We have covered all these, and we are going to talk about ventricular hypertrophy. These are my affiliations, and let's start with the module. Let's see this ECG, and let me explain one thing. Whenever you comment on hypertrophy, because the hypertrophy diagnosis is based on voltage criteria, and voltage are represented by the height of these waves or depth of these waves, you must always make sure that ECG is recorded at standard deflection. Now these boxes, they show the standard deflection. If this box is 10 millimeter, which is the case here, or the 10 small square, that means the ECG is recorded at standard deflection. Now sometimes they may be recorded at double the standard or half the standard deflection. Accordingly, these complexes will become double in size or half in size. But one thing tricky is that even if you notice these, sometime machine will automatically change the deflection when the precordial leads start. Why? Because precordial leads are typically taller than limb leads. So machine will sense that these complexes are too tall and will not fit in the paper. So it automatically reduces the size of the deflection, and that will be shown by separate boxes here. So if you see separate boxes here, then criteria of precordial lead should be applied according to these boxes. So I think you first note this one and then note if there are additional boxes here. So after making sure that ECG is recorded at standard deflection, let's proceed with the analysis. This one is a rhythm strip. It is normal PQRS, PQRS. It is a sinus rhythm, and it is important to rule out any abnormal rhythm because hypertrophy criteria do not apply if it is not sinus rhythm. So this is sinus rhythm, and one thing which is immediately obvious on this ECG is that the complexes are too tall. But let me show you periodically the diagnosis you have figured out. If you have not, I'm going to just show it here. It is left ventricular hypertrophy. Now let me show you how do I say that. First we see the various criteria. I'm going to apply one criteria. First of all, we see S wave in V1 or V2, and we count whichever is the taller one. And then we see R wave in V6 or V5, and count whichever is taller. And whenever you measure the height, you have to subtract the S wave. For example, when I have to measure this one, I will have to subtract this one. So you take the total sum, the algebraic sum of R wave. So we notice the S wave in V1, V2, or the R wave in V5, V6, we take the taller ones and we sum them up. So that is the criteria. Now, why do we take R waves on V5, V6 and S wave in V1, V2? Because both these waves, they actually represent left ventricular depolarization. So this one R wave and this S wave both indicate left ventricular forces, and we want to sum them up. Why do we want to sum them up? Because one side may be affected by some intervening structure like lung and ribs. So I think this is the practice. So we'll sum them up, and there are certain figures. If it is more than that, it is left ventricular hypertrophy. I'm going to show you that figure very soon. Then we see R wave in limb lead 1 and S wave in limb lead 3, and we again sum them up. R wave in limb lead 1 and S wave in limb lead 3 both represent left ventricular forces, and we are looking for left ventricular hypertrophy. And third, there is a single criteria, AVL. AVL is left ventricular lead. So if the QRS complex is taller than a certain height, then that will also fulfill the criteria. Plus, there may be additional changes in the form of ST depression. ST depression here, it is not mandatory, it is not the requirement for the hypertrophy pattern, but many patients actually they have ST depression. So some of the criteria, they use ST depression also, they give weightage to ST depression also. ST depression may be just the reflection of abnormal depolarization because of the increased muscle mass, but more importantly, they actually indicate coexisting ischemia. This is important because we know two people with hypertension, one with hypertrophy pattern, the other without hypertrophy pattern. The one with hypertrophy pattern is likely to have more serious prognosis because we consider left ventricular hypertrophy as morbid condition, as a poor prognostic indicator. So it is important to see if these changes are present. So formally, these are the criteria. There are three different criteria. I'm using these Sokolov lines for the sake of simplicity, and I've already shown you, but let me repeat them. R wave in V5, V6, this one. No, sorry, this one. R wave in V5, V6, we will take the taller one, whichever of the two is taller. S in V1 and V2 or V2. This one or this one. I should have taken this one because that is actually bigger. So whichever is bigger, we add them up, and if the sum is 35 or more, the criteria of left ventricular hypertrophy is met. Then we take the limb leads, R wave in limb lead 1 and S wave in limb lead 3. If the sum is 20 or more, the criteria of left ventricular hypertrophy is fulfilled. Then R in AVL, if that is more, this one is more than 11, another criteria is met. More the criteria are met, more definitive the diagnosis will be. You can of course make the diagnosis even if one of these three criteria met, but if the more criteria met, then there will be more definitive diagnosis. Then if VAT is more than 0.5, what is VAT? VAT is a short of ventricular activation time. Now, if you take a QRS complex and if you see how from the very start and till its peak, from the start of R wave till the peak of R wave, if you calculate the horizontal distance, if it is more than 0.5, which would be slightly more than one small square, because normally VAT is 0.4, just one small square. I think it would be zero point 0.4, yes. So if it 0.04, I think it's 0.04, yes. If it is more than 0.04, 0.05, VAT criteria is also met. Then additional ST depression here that adds to the diagnosis, and left axis deviation. Now, I mentioned in my earlier lecture, in left ventricular hypertrophy, there may be left axis deviation, but may not be too much. Why? Because the QRS axes are already predominantly determined by left ventricle. So if left ventricle hypertrophies, I think there may be only subtle left ventricular left axis deviation, not to the extent we see in left anterior superior hemiblock or left fascicular block, anterior fascicular block. If there is differential within the ventricle, then there are more chances of axis deviation than a differential developing between left ventricle and right ventricle. So there may be some axis deviation also, but that is not the required criteria. So I hope this was clear. You will be able to make a ECG diagnosis of left ventricular hypertrophy. Once you make the diagnosis of left ventricular hypertrophy, then of course you can figure out what may be the cause. It could be due to hypertension or some other disease. So the causes of left ventricular hypertrophy may be hypertension, aortic stenosis. What is common between these two conditions? Both of them, they offer outflow obstruction, and outflow obstruction actually promotes concentric hypertrophy, and left ECG basically shows concentric hypertrophy, not eccentric hypertrophy. So there may be many other conditions, but I'm just going to show you two here. Now, this is another ECG. Let's see what is the diagnosis here. Sinus rhythm, there is no continuous rhythm here, but we can tell that this is sinus rhythm. Now, if you see these complexes in limb lead 1, what is most noticeable is very deep S wave. Normally, limb lead 1 is almost purely an upward deflection. There is no S wave, or if there is S wave, it is very, very small. In this case, it is bigger than R wave in the complex, limb lead 1. And take the example of V6 also. In V6, normally we have predominant R wave. There may be no S wave or a very small S wave. In this case, there's a fairly big S wave also. And you know, S wave in limb lead 1 and S wave in V6 both represent right ventricular forces. And in V1, there's a tall R wave. This tall R wave in V1 also represent right ventricular forces. And there is no right bundle branch block pattern, because that will also produce similar changes. So right bundle branch block is not there. Right ventricular forces are predominant. So the diagnosis is right ventricular hypertrophy. So the criteria are, if you have in limb lead, if you have S wave which is bigger than R wave, S wave which is bigger than R wave in the same complex. So that is the criteria, or S wave is bigger than 7 small squares. Here again, if the S wave is bigger than R wave in the same complex, or if S wave is bigger than 7 millimeter. Here again, so these criteria are the indicate right ventricular hypertrophy. I'm going to show you the criteria formally here. A prominent R in V1 here, which is either more than 7 millimeter, which is actually the case because one large square is 5 and it is definitely 8 small squares. So that fulfills the criteria, 8 millimeter, or RS ratio is more than 1. RS ratio more than 1 means that R wave is bigger than the S wave. In this case, there is no S wave at all. So this is definitely much more than the required criteria. A prominent S in V6 here, S wave in V6, or which is more than 7 millimeter. In this case, it does not fulfill the criteria. It is not more than 7, but SR ratio is more than 1. That criteria is also not met here, right? In right ventricular hypertrophy, you may not meet all the criteria simultaneously. Criteria is met here, but not here. Criteria is met here, but not here. So this one is not actually meeting the criteria, but still we will make the diagnosis of right ventricular hypertrophy. So a prominent S and V6 more than 7 millimeter or SR ratio more than 1. Right axis deviation. This patient has got right axis deviation. You can immediately let, because in limb lead 1 normally the complex is upward. If the downward deflection is bigger than R wave, that means the axes are definitely more than 90. But I just calculated it is 110. So 105, 110 right axis deviation, that will also fulfill the make the criteria. This is actually negative criteria. There should be no right bundle branch block, because you will have the same morphology and you will have all these criteria met in right bundle branch block also. But right bundle branch block QRS complexes should be much broader than 0.12. And the true posterior wall STEMI, because in true posterior STEMI, if you remember my earlier module, R is tall here. So you have to rule out those situations. Only then you can make a diagnosis of right ventricular hypertrophy. So the diagnostic criteria of right ventricular hypertrophy are even more insensitive than left ventricular hypertrophy. So these are the causes: COPD, pulmonary hypertension, pulmonary stenosis, Fallon's tetralogy. I'm sure there's a pulmonary embolism also possibility. So the other causes also, but just very brief. I'm not going to go into the detail because we are just discussing the ECG. So that was it. I hope this module was useful and you have learned how to make an ECG diagnosis of left ventricular hypertrophy and right ventricular hypertrophy. I told you at the outset these criteria are not very sensitive. If you're really interested to know if somebody has left or right ventricular hypertrophy, you should opt for echo. But when you're diagnosing ECG, you must never miss right or left ventricular hypertrophy, because if ECG criteria are met, it most probably the condition is already fairly advanced and you don't want to waste any further time. So I think that is the lesson. Thank you very much. I am Professor Azizur Rahman from Medurstand, and I really look forward to see you in my next video, which will be on some other topic on ECG. Thank you very much for your listening.